I'm delighted to introduce co-presenters Kath Thorburn and Michelle Everett. Kath is a mental health education consultant, senior occupational therapist, mental health, with 20 years' experience in mental health. She has a commitment to the concept of recovery and what this means for mental health practice and services. She delivers professional development workshops and postgrad courses on recovery-orientated practice. Michelle Everett. Michelle is a clinical psychologist and coordinator of the postgraduate adult mental health programs of the New South Wales Institute of Psychiatry. She's also an official visitor, and she's recently co-written and coordinated new postgraduate units regarding the impact of trauma, and has contributed to the teaching of workshops and units of study regarding recovery-orientated practice and systems at the Institute of Psychiatry. She's worked in numerous mental health settings, including a period in Canada where the impact of intergenerational trauma on First Nations communities is readily acknowledged. And the presentation is entitled Trauma-Informed Care and Recovery-Orientated Practice, a Mutual Relationship. Thanks very much.
I don't know about a long journey getting from there to here. It's felt like a long journey getting from this morning to this afternoon. So thanks for hanging in there and sticking around for the end. So I also wanted to acknowledge Sandy Watson, who unfortunately couldn't be here today, but who has worked very closely with Michelle and I around these issues, and who we wouldn't have a lot of these ideas if it wasn't for Sandy. So I just wanted to mention that, along with many others, Deborah included in that. So we've been asked to talk about the relationship between recovery-oriented practice and trauma-informed care, and it's interesting because it's not really being talked about an awful lot, and I guess we're not saying that we're going to be definitive here. I guess we see ourselves as contributing to the conversation that we hope will continue beyond this conference. But essentially they are, as we would see it, two different concepts that have emerged from the same broader social and philosophical influences, and in that way they're very, very much related. So today what we'd like to do is talk a little bit about how we see that relationship, a brief overview of the two approaches, obviously trying not to be too repetitive around some of the material that's already been covered, but just building on that, and chatting a bit about service transformation, which, as we get to the end of today, is obviously something on people's minds. The other thing I just want to mention is the term recovery is not it's not a universally accepted term. It's a term that's starting to be contested more and more, probably largely because of the colonisation of this term by mental health services. So when we talk about recovery, we are not talking about clinical recovery from a medical perspective. We're talking about personal recovery as it's understood and defined in the literature written by people with lived experience of recovery. So that's where we're coming from. Other words that have come up today that are used are words like transformation, reclamation, self-writing, and just living a life. So in terms of the relationship between trauma-informed care and recovery-oriented practice, this is sort of how we see it. First of all, I think we're starting to recognise that recovery has really emerged as the first post-institutional era mental health philosophy, okay? And over the last 20 years, that philosophy has really started to be defined more clearly and recognised to the point where there is now a mandate in most Western countries for mental health services to be recovery-oriented. Now, we're still very much in the process of working out what that means, and I think very much, tentatively starting to think about it and making a lot of mistakes along the way. And when I say mental health services, I'm not just talking about public mental health services, I'm talking about the whole range of services that are involved in supporting people who have a diagnosis or experience of mental distress. So really what we do know is that recovery requires us to think about the whole person, the whole of the person's life, and obviously that includes the experience of trauma. Now, the other thing we know, and it's already been talked about a lot today, is that the prevalence of trauma among people who have a diagnosis is extremely high, and the impact is profound. So really, you can't have a recovery-oriented service if you don't understand and respond to trauma. It's a really important part of that. So there's a lot of common ground between these two concepts, and I just wanted to briefly go through, I guess, our perspective on this. First of all, and this is one of the reasons why I think it is a hard shift to make, because they address underlying assumptions and beliefs that have been held for a long time, and so it is, a lot of people are talking about paradigm shift, and that is a process that's uncomfortable. People do resist that process, so I think, you know, these are the sorts of things that we need to think about. How do we address this shift in the way we kind of understand these experiences? So the kinds of beliefs we're kind of really thinking about now is that mental distress is a legitimate and valued human experience. You know, what happens to people can impact on their mental health and mental distress. That symptoms and behaviour are valid responses, normal responses to abnormal situations and experiences. Adaptations was the word that Kathy used, and that people can recover, that healing is possible. So these are some of the underlying beliefs and assumptions. We can't say this enough. It's absolutely crucial that you know, the emphasis is on lived experience understandings, and that we need to work from that position. We need to recognise self-expertise, valid efforts to cope, and recognise that when people who have these experiences are involved in identifying how best to work with them and respond, we actually end up with much more creative options that are far more satisfying for everyone. So we're doing ourselves and consumers or service users, survivors, a real disservice when we ignore their expertise. The other thing is there's a real tension, isn't there, between what services do and what people need. And safety came up just now. You know, what services do to achieve safety isn't always experienced as safe. Yeah, and that damages people, and the silencing too. So we'll talk a little bit more about that later in the presentation. You know, we talked a bit about evidence-based practice. There's a strong evidence base for these approaches. It just depends on your perspective of what counts as evidence, and so that's another shift that needs to occur, is our understanding about, well, what is it that counts as evidence? And, you know, I guess this takes us back to the first point, really, doesn't it? That, you know, what we're talking about is not an add-on. We can't say, oh, well, let's add a little bit of trauma-informed care to our services, or let's add a little bit of recovery-oriented practice. This involves a fundamental shift in the way we understand the experiences that people have, and therefore how we respond. So it takes unlearning, I think was another word. Maybe it was Judy talked about unlearning, and that's really important, and that's uncomfortable too. So we also, when we're thinking about that educaring approach, which I really like that way of framing, because we do need to kind of engage people in these conversations in a way that doesn't turn them away, and workers, I guess I'm talking about there. So really, really, I guess, if we're talking about recovery-oriented services, what does that mean? In essence, it means that we're moving from how do I treat this client to what does this person need to lead a meaningful and satisfying life. So, for example, if we're faced with a person who's experiencing voice hearing, we're moving from a position where we might have looked at them and thought, oh, they've got auditory hallucinations, you know, they're not really real. It's a symptom of psychosis. Maybe this person has schizophrenia. They definitely require medication, and we're probably going to give them a bit of psychoeducation as well so that we can train them into our understanding of their experiences. So we're really moving from that perspective to very much a meaning-making exercise, a sense-making exercise. How does the person make sense of their experiences? You know, what are they already doing to manage? What's the degree and the source of their distress? You know, how can we learn from others who've had these experiences and what might be helpful for them? So what resources does the person need? In essence, what we're kind of really talking about is that we're strengthening the person, not weakening the voices, but in strengthening the person, naturally then they gain more control and power over those experiences. And certainly I'm not suggesting that medication is not ever a part of this sort of work, but it's a judicial, thoughtful use and thinking about what's the aim and the purpose of medication. A lot of people find that the stamping out of their experiences, the medicalising their experience is actually more unhelpful and inhibits and hinders recovery. So then, gosh, I could talk for days on recovery and recovery-oriented services, so I'm going to finish this up in one more slide. So this is a real for anyone who knows me, this is a real challenge. But basically what we're talking about is that we're moving from an illness-oriented understanding of people's distress to a view that these experiences are legitimate, they're meaningful, they're part of what it is to be fully human. Now, when you think about that, you can see how that really influences shifts in services. If I understand someone's experiences to be illness-oriented, then of course medication and therapy delivered in hospitals and clinics by health professionals makes perfect sense. But not if I've got a broader view. And it's not to say that those services are completely ignored, but just that they're part of the picture. They're not the whole picture. They're not the sole type of service that we should be offering people. So when I see these experiences as legitimate and meaningful, then I start to think about, wow, we really need peer support here. We need people who've walked this territory before. You know, currently all the maps are kind of really drawn by people that never stepped foot on the landscape. So we need to really involve peer workers and services that are really making great gains towards this end have very high numbers of peer workers in their services. Okay, I keep reminding myself, stop here, Kath, and move on. So lived experience. I think this is one of those crucial understandings that until you can really understand the importance of lived experience as the main contributor to our understandings about these experiences of trauma, of mental distress, until we really fully grasp that, we're not going to change or transform or move forward. It's absolutely key. And then really coming from that, and this is something that I think some of our work that we've been doing with Sandy has been really helpful for me, is the research into lived experience narratives has really identified that people have very diverse explanatory frameworks, diverse ways of understanding what's happened for them, their experiences. Now, yes, for some people, they do have a biological understanding of their distress, that it's an illness. And probably they're the people for whom current systems work quite well. But there are also a lot of people who have other explanatory frameworks, trauma being a very common one of them, but also things like political, spiritual, creative, developmental, different, and people can hold a number of these different explanatory frameworks at the one time. So what we need to do is we need to acknowledge this, and we need to offer alternatives that respond to the whole range of explanatory frameworks. And I don't have to hold the same explanatory framework as someone else in order to do that. You know, this is something that's about meeting people, understanding where they're at, offering the whole range of services, the whole range of approaches.